Thank you, Professor Rubiano, for your excellent presentation. We proceed with Professor John Ouma, speaking on cervical traction, close or open reduction. Professor Ouma, please.
Good. Thank you very much. I'll just share my screen now. Thank you. Let me start from there. I hope you can see my screen. Good.
Yes, we can.
Yes, so thank you very much for the invite. I'm just going to spend the next 10-15 minutes speaking about this question of cervical traction, closed or open reduction, something that I'm sure all the participants in this Zoom meeting are well familiar with. Nevertheless, it is a good thing to go over, familiar territories. So very briefly, the cervical spine, as we all know, is, has its unique anatomy. And I don't think one really needs to, to elaborate much about this, but the specifics about the articulation of C0, which is the occiput, C1 and C2, very unique synovial joint and ligamentous sort of orientation that maintains its stability. And then, of course, the subaxial spine, which is quite different. We know that the C0, C1, C2 area, apart from those unique joints that join them, we also have this washer sort of function of C1, which serves almost as a washer between the occiput and C2. And it's a very unique sort of situation. There's a lot of room for the spinal cord in that area. And so when we talk about destructions in the cervical area, we rarely sort of mention or rarely discuss, issues around that area for reasons that I will go into just now. The subaxial spine, however, is by far the commonest area that we're involved with when we come to traumatic compression of the spinal cord. And perhaps the reason for that is the fact that the spinal cord has far less space, available to it in the subaxial spine, as well as the fact that this part of the spine has these discs in front, apart from the vertebral bodies, large vertebral bodies and discs in front, all of which can compress the spinal cord in certain situations, as well as when you look posteriorly, this unique arrangement of facet joints, which as we shall see, and as we all know, again, under certain conditions of trauma, can become the compressing lesions. So why do we need to decompress the cervical spine? Now, this is an obvious question, but I'll just go through the obvious answers. So the spinal cord cannot tolerate compression. And once there is significant compression, there is obviously direct trauma to the spinal cord, as we saw in the first talk. There are all the minor molecular changes that happen once you have ischemia and that kind of trauma, a reduction of blood supply, worsening of ischemia, the question of instability, worsening the neurology, pain, and so on. But also the fact that the faster we decompress a compressed spine, the better, the neurological outcomes. And by the same token, with any delay of decompression, we obviously have significant outcomes, which in the case of the cervical spine can be completely disastrous. So I think the question of why is not really important. This question also is another obvious one. What are the causes of post-traumatic cervical cord compression? Now, again, there are many. You could have bony fragments, etc. But I just want us to concentrate for the purposes of this talk on the facet joint subluxations, which in fact are, I would say, certainly in our practice, the commonest reason why we suddenly have to jump out of bed and start decompressing a spinal cord. So that's what I'm going to concentrate upon. So what are the facet dislocations of the subaxial spine? Essentially, what we have in the subaxial spine is this unique arrangement where the facets lie in each other, the superior one lying posterior, or the inferior facet of the superior vertebra lying posterior superior to the inferior facet, or rather to the superior facet of the inferior vertebra. It all sounds like a word salad, but I'm sure you all get what I mean. So there's this unique arrangement which, under certain conditions, specifically flexion destruction, one can have a situation where there's significant flexion and destruction resulting in the first case, that subluxation and then perching. And should that continue, this particular facet coming to rest in front, or the inferior facet coming to rest in front of the superior facet. And that creates a situation where the spinal canal gets compromised and the spine gets compromised. And there could be other issues as well in terms of what happens to the disc, which too may move and may become part of the problem. In addition to that, depending on the nature or the vector of the force, one could also have fractures. So you may not just have a dislocation or subluxation of the facets, but you could also have a fracture dislocation where either one or both of the facets fracture. By the same token, you could have this on either one side, in which case we have a unilateral problem, or both sides, in which case you have a bilateral problem. So unifacet dislocation is a unique one. And the thinking is that in addition to the flexion destruction mechanism, you also have a bit of a rotation mechanism, which favors the one side, favors or disfavors the one side in terms of the fact that that facet experiences far more stress and jumps over its facet, over its inferior facet, whereas the one on the other side doesn't. Now, this is a unique situation. It has been described as the most missed injury, cervical injury. In other words, unifacet dislocations are the most missed injury, in casualties across the world when it comes to cervical spine trauma. And it's easy to see why it can be missed if one is not very careful. If one looks at these x-rays, without paying too much attention, one may miss some of the obvious signs. And one of the signs that we see with unifacet dislocation is this so-called bow tie sign, which has been shown here. The other sign that has been talked about is the reducing laminar space. If you look at the laminar sort of space from your spinal laminar line to the posterior vertebral space, when you have these unilateral facets, it sort of tends to decrease. So one has to be careful. Otherwise, one can miss it. And, and that can have disastrous consequences for the patient. However, bifacet dislocations in our practice are the commoner dislocations of the subaxial spine that we see. One of the things that you immediately notice is that when you have bifacet dislocations, the subluxation tends to be, at least like a grade 2 and above. You get these large subluxations. With the unifacet, you may get like up to 25% or no more than that. But here you get your 50, 75, God forbid, you can get a complete spondyloptosis. When one looks at the CT scan axial sections, again, we're all familiar with the hamburger sign, the normal sign or the normal situation, the so-called hamburger sign, where we have the normal facets, as well as the headphone sign. I'm pretty sure we're all familiar about the headphone sign, where you've got the uncinate processes of the inferior vertebra sort of acting as a headphone on the superior vertebra. And all this gets lost. If you've got a bifacet dislocation, it looks like the hamburger is now sitting inverted and the headphones are lost. So these are just some of the signs that one can look for, perhaps just for the benefit of some of the younger members of the meeting. All right, so now I'll just come back to the nitty-gritty of this talk, which is really about reducing facet dislocations. I just want to concentrate on facet dislocations. So how do we reduce facet dislocations? Now, there are really 4 main ways in which we do that. And I'll go through each one by one. So cranial traction, or or so-called tongue traction or Gardner-Wells traction is probably the most known and I would argue the most used technique around the world. It's certainly the one that is perhaps easiest to implement in a casualty situation. But interestingly enough, if you go around, especially many primary tier and secondary tier hospitals, and ask to see the tongues or the Gardner-Wells tongues or skull traction tongues, many times they're not available, or if they are available, one half is missing and so on. And this is a huge problem. Even where they're available, the knowledge as to how to use them is a problem. And this, as I'll explain in future slides, is a significant problem because cranial traction, even though it's highly effective, it is not generally used as well as it should be at the point of first contact. And many of these patients eventually are transported over many hours and many miles to a place where they can be assisted long after the window of opportunity has passed. So manual traction is another one we'll talk about. And then, of course, the open approaches, which may be anterior and posterior. So again, just to go through the obvious for many people here, the Craniotraction, which employs, in its commonest form, Gardner-Wells tongs or various other tongs that are applied to the skull. But there are problems with this. The patient must be awake because you're going to distract the dislocation. You've now diagnosed that there's a subluxation, and you're going to apply pressure in order to try and pull this. Usually, you apply pressure in flexion, because if you apply an extension, you tend to lock the facets. It has been said that if the facets are fractured, then they tend to reduce much easier, and that's perhaps true. Otherwise, you distract the patient in flexion, which is in a sense the same manner in which they actually sublux in the first place. And once a facet's purged and you relax it, you then come down. We all know that we usually start with around 5 kilograms weight, X-ray to make sure there is no atlanto-occipital issue, and then increase the weights every 10 minutes by, say, 2 to 5 kilograms per level until we get purging, and then we reduce and allow the facets to reduce. There are a number of problems with this. I've mentioned that many hospitals in the primary and secondary care setting where the patients do arrive don't have these devices. If they have them, they haven't been used for 6 months. So when a patient arrives, nobody knows where it is, or the screwdriver is missing and so on. And that's a huge problem. You also need to know the techniques as to how to attach the pulley. You need to know about, say, the two mattress mechanism. You need to know about the directions, distraction in flexion, distraction neutral, distraction in extension. And there has to be a mechanism for repeated X-rays, presumably a C-arm, like in your casualty setting, where you can repeatedly X-ray, because you can't be putting weights and not getting real-time or frequent X-rays to see what you're doing. So these are the problems. And on top of that, you must commit to examining the patients neurologically to see that they're not deteriorating. So all these are the problems with this technique. Nevertheless, I think there's room for education and improvement in the way this technique is done. So what about manual reduction? Now, this is another very interesting technique. And as I'll show later, it has been touted to be far more effective and perhaps far better than the skull traction that we talked about. So under manual reduction, one goes to theater, takes the patient to theater under general anesthesia and relaxation, and one manually reduces the dislocation. Now that sounds perhaps horrendous to some of the purists who grew up only using craniotraction, but in fact, there's a lot of literature that suggests that in fact we should rather be doing manual traction because it's quicker, it's easier, and the argument about neurological deterioration has been countered by the fact, or by the argument, the counter-argument, that in fact, if you reduce these patients as soon as possible, you're doing them a much bigger favor than if you try to reduce them with craniotraction over many hours sometimes, and not really knowing where you are. You'd rather have them asleep, reduce them, wake them up, examine them, and then, if there is a problem, deal with it. So this has been, and there is literature I'll show that suggests that this is the manner in which we should be doing things. And then, of course, the open techniques. Now, open reduction techniques, many patients, usually the open and closed, rather the open anterior and posterior techniques are usually used as a second or as a fallback measure where the closed techniques have failed. So for instance, you apply skull traction, and after 4 hours, you still nowhere, then you decide, well, let's go to theater and reduce this. And so what happens, there are many techniques, but this is the one with the Cloward, rather with the Casper pins and the intervertebral destructor, where one tries to get either Casper pin destruction or an intervertebral spreader under real-time fluoroscopy to make sure that as you do that, you actually watch the facets dislocate. Once they purge and then go back into position, you then reduce your destruction. So that is the open technique, and the advantage being that you can then at the same sitting complete the fusion, usually in this case an ACDF type fusion. Posteriorly, one can also do this posteriorly, and with the posterior technique, again, one opens and one essentially physically gets, in this case, this is an illustration of a unifacet dislocation, where one physically gets the facet back in its place. And there are many techniques described with the bifacet, for instance, putting retractors on the spinous processes and distracting them in flexion until they return to normal. And then once that is done, one can then complete a posterior fusion. So as one can see, there are many ways of skinning the cat. However, that's perhaps the easy part. For the last part of my talk, I'll talk about the controversies, which is really the hard part of this whole question of facet dislocation. There are a number of controversies, and it's well worth going through them. And the first one is the question of a pre-reduction MRI. Is it ever a necessity? Now, if you want to get spine surgeons hot under the collar, you should just start this discussion, because people tend to have very strong positions on either side. And I think the truth is perhaps somewhere in between. Is it ever a necessity? I personally think that where patients are intact neurologically, and we do get patients who are intact neurologically, even sometimes with bifacet dislocations, intact, or at most they just have perhaps a radical that's weak and so on. In cases like that, the question is, should you get an MRI? Because the patient has everything to lose if anything goes awry during the reduction. So one would argue that if an MRI is accessible and the patient is intact, it may be an idea to get an MRI to ensure especially the behavior of the disc. Say, let's say we're talking about a C5-6 subluxation. What is the disc at C5-6 doing? Because not infrequently, these discs have moved back and they're sitting behind the body of C5. And when you achieve your reduction, you now have a reduction with a huge disc in the canal space causing acute spinal cord compression. So that has been rubbished by many as either infrequent or not significant. There is literature that says that even where that is the case, and you reduce the disc, patients do not necessarily deteriorate and so on. And so one should not waste valuable time getting an MRI. But I still think that if an MRI is accessible and the patient is intact, then that is something that should be looked into. In other cases, I'm not so sure. The other controversy is how quickly should reduction be achieved, and I'll show you one aspect from the South African courts. What is the most effective method of reduction, which speaks to controversy number 2? Should we be teaching our students skull traction as a primary method, or should we be encouraging manual reduction? At what point should we be advocating for open reduction? So these are all controversies. The strategy between uni and bifacet dislocations, there is literature suggesting that unifacet dislocations are particularly difficult to reduce with skull traction. And I don't know, we'll perhaps hear from other panelists if that is the experience. And then, of course, the controversy of anterior versus posterior. So just to rush through this, I think I have 5 minutes left, but the question of pre-reduction MRIs, as I have said, there is a lot of literature, and I've just highlighted some of the literature, and you could actually fill 10 pages with the literature arguing for or against pre-reduction MRI. The reality is many places where patients arrive at with bifacet dislocations or unifacet dislocations do not even have an MRI anyway. And so it would be wrong to expect people to wait or to transfer patients without dislocating them because of MRIs. But I still think that one has to be careful where the patients are intact neurologically. There is, I think, a role for that. But in other cases, I think I'm quite happy to suggest that we should be reducing the patients as soon as possible and then obtaining MRIs if we can, or for that matter, CT myelograms or whatever else we are able to get if there is a concern about the neurology. How quickly should reduction be achieved? Now, the South African courts in 2015, there was a case involving a rugby player who had a bifacet dislocation, and there were a lot of things that went wrong, and I think the reduction only happened after 14 hours. In any case, the matter ended up in court as a negligence case, and ultimately it was argued all the way to the Constitutional Court, which has now made a declaration that these facet dislocations should be reduced within 4 hours of injury. So this now, for those practicing in South Africa, is now law. And it's something that in every spine meeting we have, is sort of a source of much amusement, because in many cases, the patients do not even arrive at the first point of center or at the centers where reduction can happen within 4 hours. And so where does that leave you if a patient has arrived 5 hours or 6 hours after the injury. I mean, the courts say there must be a reduction within 4 hours. You're now in negative time and so on. And again, even if the patient arrives within an hour or so, and you're reducing the patient with cranial traction, which is a recognized method, and now it's 1 hour and 2 hours and it's not happening. I mean, at what point do you abandon this and get to either manual traction or open reduction if you're having one eye on the patient and one eye on the law? And finally, who says 4 hours? How do we know what the spine can tolerate? And so there are all these questions. And so the question, we would all agree that it should be as soon as possible. There can be no argument that a spine should not be under pressure, but the question of whether these things can be stated in law, as in 4 hours or 2 hours or 5 hours, is, I think, highly controversial, and it will remain controversial, till the end of time. What is the most effective method of reduction? We spoke about this earlier, about the different methods, and I've just used these two papers more than 10 years apart. This one from China, sort of talking about the essentially reduction, manual reduction versus cranial traction, showing that actually this ZR technique, which is the Z-shaped manual traction, is safer and more effective than the traditional skull traction for close reduction of subaxial facet dislocation. This is another paper. It's been around for much longer. And again, even these people who reviewed over 4 years manipulation for cervical dislocation under general anesthesia also showed that this is a safe and effective procedure for pure cervical spine dislocation. So the reason I'm putting them up here is because there has always been a source of concern. How do you put people under general anesthesia if you cannot assess them? Because we always emphasize that when you reduce these dislocations, you must be able to monitor them neurologically. How then do you advocate for reductions under general anesthesia when you cannot monitor patients? But in fact, the literature suggests that that's not an issue, that in fact, you should reduce them. The reduction is what's more important rather than monitoring their neurological state. Because once you reduce them, you're saving the cord from further injury, and then one can take it from there. So this remains one of the confusions. Anterior versus posterior fixation, there's been a lot of discussion about that. Most of us are familiar with the anterior, the ACDF and ACCF techniques. So for most neurosurgeons, orthopedic surgeons, it's a familiar technique. There's much less muscle injury, there's much less blood loss. And I think, generally speaking, most of us are quite happy with that. But in some cases where the anterior reduction fails, and in my personal experience, this has been the case with neglected facet dislocations. We do see quite a lot of neglected dislocations, which have been missed for several weeks, and then they arrive. In those cases, frequently posterior reduction is the easier way of doing things. And if you reduce posteriorly, do you then reduce posteriorly, fuse posteriorly alone, or do you reduce posteriorly, turn the patient over and do anterior fixation? I think I'm quite happy in those instances to do a posterior fixation, but in select cases, turn the patient over and do an anterior fixation as well. So this remains one of the controversies. So thank you very much. I hope I finished in time, but those were the few comments I wanted to make. Thank you.
Thank you, Professor Ouma, for your excellent